The first consultation with a pain specialist is a vital aspect of care. It is important to not be rushed during that first consultation. The first consultation is about telling your story. The first consultation is about the history of pain, perhaps what caused the pain, what the pain has done to you, what the pain has done to a person's function, what the pain has done to their ability to enjoy life. It is important that that first consultation sets the scene. The aim of the consultation is to give somebody a diagnosis or diagnoses, what the pain is, where it's coming from, perhaps what even triggered the pain, what the effects of the pain are, which is so important. So how is the pain changing a person? How is the pain changing a person's function? How is the pain changing the person's ability to enjoy life? How is the pain changing that person's ability to interact, to socialize, to work, to be productive, and ultimately have a good quality of life? So that is the first consultation. It's important to understand somebody's pain. It's important to go through the minutiae at some points. Sometimes if pain is very complicated, that first consultation is not enough. Really, one wants to come away from a first consultation with questions answered. One wants to come away from that first consultation with hope. I mean, it is a bit of a cliche, but it really is important to have hope in this is not going to be the way forward. There is a plan, there is a pathway looking forward. The aim is to be proactive. The aim is for somebody to feel motivated. You don't want medico-legal talk, you want straight talking. You want clarity, you want a plan of action. That's a very important aspect of pain. And as I say, pain management is not like running a race. Pain management is like running a marathon. It takes time. Things change along the way. You do something, you assess the pain. You do a treatment, you reassess the pain. It is a slow journey for some. Not always, but generally speaking. So how do you approach good pain management? Well, it's a stepped approach. It is a plan where if you have a range of therapies available, starting from a simple therapy all the way to a complex therapy, for example, a simple therapy might be some lifestyle changes, changing the way one moves their body, changing what you put into your body. So for example, smoking is an important factor with pain. We know that smoking somehow can make pain worse. We don't know if it's a chemical factor related to the nicotine. We don't know if it is the nociception, which we'll come to at another discussion, and how it responds with different chemicals within the body. So there are some simple aspects that might be able to address pain, all the way to some complex aspects, and that might even include surgery, sometimes pain-related surgery, sometimes surgery by a spine surgeon or an orthopedic surgeon, for example. So you start off with the simple approaches, but you've got to have that broad aspect of pain care that you understand is gonna occur or could occur. So for example, let's have a look. So a stepped approach is what we call it. So you start off with one step. If that's not enough, it doesn't work, you move on to the next step. If you don't do well, you move on to the subsequent step. But if you do well, you pause. If you do well, you can come back down a step or two as well. So it's a changing process. Early therapies, as I mentioned, might start off with some lifestyle changes. Changing the way you eat, changing alcohol consumption, changing smoking. So some simple aspects really. We understand that the simple things that somebody can do to their life, which we'll discuss at another point, can have a profound impact on your levels of inflammation. Anti-inflammatory diets. We know that people with chronic pain don't move as much. You get stiff, you get weak, and it's that stiffness and weakness that causes more pain and changes the pain. And so if we can get moving a little more, it doesn't have to go from 0 to 100, it can go from 0 to 5. So small little steps. Lifestyle changes are very important, and everyone is different, and everyone needs different approaches to that first step. What about Second line therapies, so you might change medications, you might tweak medications, you might even drop medications, you might even change the combination of medications. So medications and an approach to medications are a very important aspect of early and of course long-term pain management as well. Ultimately, we want people to be self-managing on very little medications because that limits the side effects and risks of medications. As anaesthetists, as pain interventionists, it's important to sometimes help diagnose the pain. So we can use a nerve block or a joint block that can help us confirm where pain comes from. If we know where the pain is coming from, sometimes we can apply therapies. So if I know pain is coming from a facet joint, I can do a joint nerve radiofrequency ablation to desensitize that joint, sometimes for months and sometimes even years, multiples of years. So it's important to use interventions to help diagnose and also help treat pain. If somebody's got central sensitization, their body is sensitized, hypersensitive to light, sound, touch, we can sometimes use an epidural injection to help desensitize that hypersensitivity, just dial down that volume of sensitivity and pain. So using some injection therapies, guided by science, guided by expertise, guided by experience to help understand, to help treat the pain. It's not the first step, it's one of the subsequent steps. Even neuromodulation. So neuromodulation is what we term targeted therapy. So many years, for many years we've been using chemical approaches to medication, chemical approaches to disease. So you take a chemical, you get it in your body, and it affects a process. It has an outcome, but of course it's not a targeted approach. Whereas neuromodulation is targeted therapy ultimately, and that can be targeted drug therapy, it can be targeted electrical therapy. So you put the treatment where it is needed. So for example, vagal nerve stimulation can be used to treat some forms of inflammatory processes like arthritis, rheumatoid arthritis. Deep brain stimulators can be used to target movement disorders. Cochlear nerve implants and cochlear nerve stimulation can be used to help people hear. Peripheral nerve stimulation can be used to target damaged, affected peripheral nerves to calm these nerves down. So this is another step higher. This is so-called neuromodulation, and they're very different types of neuromodulation, different forms of neuromodulation. Even other therapies might be considered. So we might work with a surgeon that says, I don't want to do an operation, it may not be safe to do an operation, it may not be ready for an operation. So for example, if somebody's too young or too old for a joint replacement, they may come and see a pain specialist to help us desensitize some of those joints, which will allow ongoing quality of life before the need for a joint replacement. But of course, if these things are not helpful, or the pain progresses, or something changes, or there are new symptoms, surgery may be an option as well. So again, it's important to collaborate with referrers, surgeons, other medical experts that are looking after somebody. So again, that first consultation is a very important aspect. It sets the scene. It puts together a plan of action, and then we put that plan of action into action and reassess and learn from how somebody might respond to a medication, learn from how somebody might respond to a joint block or a nerve radiofrequency, and then come back, re-loop, close the loop, and all the while making sure somebody is progressing, somebody's becoming more functional, somebody is becoming more engaged in society, in life, in work, in relationships. So there is a plan, there is a process. It's sometimes not an easy process, but it's certainly one that can be done, can be performed.